In this video, we will learn about the spectral Doppler waveform of the hepatic veins. So this is the diagram in which we can see the three hepatic veins, that is left hepatic vein, middle hepatic vein and right hepatic vein. This is the ultrasound probe. So we can see that left hepatic vein is seen in the left lobe of the liver, which is dividing segment 2 and 3 from the segment 4A and 4B in the left lobe. And this middle hepatic veins along the Cantley's line, which is an imaginary line between the middle hepatic vein and GB. So this divides right lobe of liver and left lobe of liver. And middle hepatic vein separates segment 4A, 4B from the segment 5 and 8 of the right lobe. And right hepatic vein, it divides segment 5 and 8 from the segment 6 and 7 in the right lobe. And all these three hepatic veins drain into the IVC, from where it brings blood to the right atrium. In this diagram, we can see the hepatic vein waveform, which is described as a triphasic Doppler waveform, however has four components, that is A wave, S wave, V wave and T wave. The flow which is towards liver away from the heart is described as retrograde flow, and flow towards the heart, that is antegrade blood flow. So in this diagram, the first wave, A wave, which is depicted by the blue color, is above the baseline and has a retrograde component of the flow which is towards the liver. And two waves, that is S wave and D wave, these both waves depict the antegrade component which is towards the heart. And V wave, it is seen in the normal patient above or below or at the baseline, and it is a transitional wave which represents only a transitional phase. Now we will see how the blood flow through the right side of the heart influences and lead to this particular waveform of hepatic vein. So here we see the waveform formation affected by the each portion of the cardiac cycle. The white arrows in this diagram depicts the wall motion of the heart. Yellow arrows shows the blood flow. So in the first figure A, we see during the atrial systole, which is followed by the atrial contraction, the blood flows from the right heart to the right atrium to the right ventricle through the tricuspid valve. However, there is also a portion of blood flow towards the liver away from the heart, that is retrograde flow, leading to the retrograde A wave, which is above the baseline. In the figure B, we can see during the ventricular systole, the tricuspid annulus, it is dragged towards the cardiac apex because of the ventricular contraction. So there is suction of the blood into the right atrium from the liver. So there is blood flow towards the heart. So it is a antegrade wave, the S wave. In the figure C, we can see that the tricuspid valve, it returns to its normal position, and the velocity of blood out of the liver decreases, and there is a transitional equilibrium with no blood flow. So there is formation of V wave, which depicts this transitional phase. In the figure D, during the diastole phase, the heart is relaxed and the tricuspid valve opens. So the blood flows passively from the liver into the heart. So there is antegrade D wave. So now we will see the physiology of normal variant C wave. As we have already seen the triphasic waveform of hepatic vein with waves as A wave followed by S wave, V wave and D wave. A wave, S wave, V wave and D wave. This C wave is seen as a normal variant after the A wave, with having a retrograde flow followed by S wave, V wave and D wave. So this here is the C wave depicted by the orange color. In this figure A, we can see as the ventricular systole begins, there is retrograde velocity begins to decrease, this retrograde flow towards the liver, it gets decreased, causing the A wave. However, as seen in the figure B, still the pulmonary valve is closed and the ventricular pressure is increasing. The ejection of the blood is not started, so the tricuspid valve, it bulges into the right atrium. So due to this bulging, there is transient pulse of increased flow in the retrograde direction. So whenever there is flow in the retrograde direction, it is towards the liver and above baseline, giving the C wave. In figure C, when the pulmonic valve opens, so the blood is ejected from the ventricle and the retrograde velocity progressively decreases as a part of normal conclusion of the A wave. So after this, the ventricular contraction will further continue dragging the tricuspid valve, which will lead to formation of S wave. Now we will see the algorithm for the systemic evaluation of the hepatic vein waveform. In this systemic evaluation, we see 4 factors such as direction of the flow, regularity of the pattern, phasicity of the waveform, and comparison of the D wave with the S wave. First, coming to the direction of the flow. Seen in the hepatic vein occlusion, we can see that at the site of obstruction, there is stoppage of the flow, which leads to the reversal of the flow towards the liver, so leading to the turbulent monophasic retrograde flow, that is above the baseline. Second, we see the regularity of the pattern. If there is irregular waveform seen in the conditions such as arrhythmia, turbulence, or patient factors, so there will be a irregular waveform both above and below the baseline. Third is the phasicity. So in conditions such as cirrhosis or fatty infiltration of the liver, we see the flow as monophasic dampened waveform, antigrade waveform below the baseline. And in other conditions such as metastatic infiltration, hepatic vein stenosis, or Valsalva maneuver or veno-occlusive disease, we also see the blunted or dampened waveform. This is the baseline and this is the dampened waveform. And lastly, we compare the D wave with the S wave. In normal waveform, we see the S wave is larger than the D wave. This is S wave and this is D wave. However, in case of tricuspid regurgitation, the S wave decreases as compared to the D wave, or it can reverse also. So in this diagram, we will see how the severe tricuspid regurgitation leads to the particular hepatic waveform. In this first figure A, we can see the atrium contraction forces the blood into the ventricle as well as the retrograde towards the liver, which is also leading to the formation of the A wave. But in the figure B, we can see that the ventricle contraction has initiated and the tricuspid annulus moves towards the cardiac apex. But due to the severe TR, the blood regurgitates retrograde through the tricuspid valve into the atrium, IVC, and the hepatic vein. So blood is retrograde, leading to the retrograde S wave, which is abnormal. As earlier we have seen, due to the cardiac annulus dragging towards the cardiac apex, there was antigrade S form. But in the severe TR, due to tricuspid regurgitation, there is retrograde S wave. And in figure C, as the ventricles began to relax, the tricuspid annulus returns to its normal position and blood is again forced out of the atrium back into the IVC and liver. So the V wave or the transitional wave also shows the retrograde pattern. And finally, in figure D, we can see that due to the atrium and ventricular relaxation, the tricuspid valve opens and there is blood flowing towards the heart, that is the passive filling of the heart. So only antegrade wave in the severe tricuspid regurgitation is the antegrade D wave, and all other waves are retrograde. So the waveform will be like A wave, S wave, V wave and D wave. Also, we can identify conditions such as constrictive pericarditis by looking at the hepatic vein waveform. We can see this extra wave between the normal D wave and A wave. This appears because of the premature reaching of the right heart capacity due to the constriction by the constrictive pericarditis, leading to the retrograde waveform. So we got brief idea how the relationship between the cardiac physiology and liver physiology is bridged, and how hepatic waveform assessment can help us to reach a specific diagnosis.